Well, welcome everybody. I'm Gene Ransom, CEO of MedChi, the Maryland State Medical Society. We're very excited tonight to have this presentation. AI in medicine is obviously one of the most important issues facing all of society, but particularly obviously healthcare. And MedChi is working hard to be a leader on it. We'd like to congratulate Dr. Ma and Dr. Radising, who were both appointed by Governor Moore to the AI task force in Maryland. And this is part of a continuing education series that our president, Dr. Padmini Radising, has set up so we can educate members on AI in medicine. And things are moving quickly. So I think as soon as we set one of these up, we need to make adjustments and set up another one. And this is going to be probably the thing that we think about and talk about the most over the next 1 to 5 years. So I'm going to turn it over to Dr. Radising. For those of you who don't know Dr. Radising, she is the current president of MedChi for at least another week, right? She's finally going to hand it off. Dr. Radising is a physician at Johns Hopkins Medicine and is an active member of the American Medical Association and has many leadership roles, including the appointment she just recently got from Governor Moore. So I'll let Dr. Radising introduce our wonderful speaker tonight and get us going. So with that, Dr. Radising, Padmini, it's all you.
Thank you, Jean. Thank you actually letting us. MedChi has been leader in actually educating physicians and being part of this Maryland physician ecosystem. So thank you for letting us do that. And I'm also glad to be the president of MedChi. And my welcome to this group today. And this is a second session on CME series on artificial intelligence. And I'm glad that we have a lot of registrants. I'm hoping everyone will join. And as you may remember, our first session provided the broad foundation and national level. And tonight's session will build on what we did and focusing on AI implementation at the hospital level. So where should we start if not Johns Hopkins, right? So with that, I'm going to introduce Dr. Sridharan. So Anirudh Sridharan, MD, is the Interim Chief Medical Information Officer for Johns Hopkins Medicine. So this includes all the hospitals, and where he leads efforts to improve healthcare through innovative use of technology. He's board certified in internal medicine, geriatrics, and clinical informatics, and practices as an adult medicine hospitalist at Johns Hopkins Howard County Medical Center. And Anirudh combines frontline clinical experience with strategic leadership to enhance care quality, provider well-being, and digital transformation across health system. Thank you so much, Dr. Sridharan, joining us and doing this talk today. So over to you.
Yeah, thank you, Dr. Radhasinga, for the really kind introduction. I think that one thing I always like to preface all of my talks with is that, well, first, let's see if I'm good at sharing my screen. Can you see my presentation in presentation mode as opposed to presenter mode? Good. I got a thumbs up. So I passed the first test. I always feel like this is, in a Zoom call, the most trying moment is getting that correct. But one of the things you may have noticed is I trained both as an internal medicine doctor and as a geriatrician, and had a career as a frontline clinician for about 15 years prior to taking on my role as an informaticist. And so I feel that really informs my my career as a technologist, where I really think technology is meant to serve our patients, their families, and hopefully make the lives of our physicians, nurses, and other healthcare workers better. And that's really always how I'd like to be able to deploy technology, both at a local level and at a system level. And so, AI is one of these things that, as Gene was mentioning, has really taken over in the mind share. And so I thought I would start really just with a thought of, well, A, I have no financial disclosures, but B, just where Johns Hopkins is with its approach to AI governance. Our experience with our, to date, largest AI app deployment, which is around an AI ambient scribe. And I'll talk about what that is and what it does. and then talk about the explosion of other AI use cases in medicine that we are looking at, not only at Johns Hopkins, but I feel, across the country and across the world. So, I think the first thing to think about is that how did we arrive at this AI moment? And like many things, Ernest Hemingway has the answer. Really, it was in two ways: gradually, then suddenly. And you may have had this in your previous talk, but I think it's always helpful to think about this, that I really feel that this moment in AI is really our third instance of AI excitement. The first one actually occurred in the late 80s and early 90s when experts in the field were really trying to develop what they called expert systems. So in medicine, there actually was an AI system called MyCin. And what was interesting about that system was at the time, AI scientists were really trying to reproduce the thought process and mental model for experts in the field. So MyCin was looking to see, could we reproduce the mental model of an expert clinician? And at the time, the state of the art really was around hand coding these kind of AI models. So you develop these really complicated decision trees. You then had computer programmers and AI experts try to build out by hand almost these decision trees. And unfortunately, that view, when it actually came up against real end users, was found to be an approach that was really brittle, really hard to maintain, and unfortunately often produced answers when it was right that clinicians already knew. So it wasn't telling them anything they didn't know about. But I think that experience was really helpful because it really pivoted the field to start thinking about AI in a different way, one that was much more grounded in applied statistics and was really foundational for the kind of AI we have now. There actually was a second AI hype cycle, which I think many of us remember, which really had to do with machine learning. And so there was at the time a lot of excitement, and still is to some degree, around these kind of machine learning models that would help in medicine to help diagnose conditions like sepsis or be able to detect patients that were at risk for early deterioration. And a lot of that foundational work was then used to really develop the kind of generative AI models that I think all of us got really excited about back at the end of 2022, around November 30th, when OpenAI formally announced the public the existence of ChatGPT. And I think at that moment, everyone realized that this was something new, different, and had the ability to be just transformational in the way all of us do work. What's really interesting about this moment in AI is how quickly medicine and healthcare in general has embraced it, because that hasn't been the case with technology. If you think about the computer revolution, healthcare was really late to that game. If you look at other major industries in the US, the financial sector, manufacturing, retail, they undertook their computer revolution way earlier. In finance, it was really starting in the 1960s, manufacturing in the 1970s, and retail in the 1980s. But in medicine, if you look as late as 2009, only 12% of hospitals in the US had what we would recognize as a modern electronic healthcare record, one that combined both physician order entry along with physician and nursing documentation, along with an integrated lab system, pharmacy system, billing, patient portal, all of that. And really, it took the HITECH Act in 2009 as part of the stimulus package to really spur healthcare organizations to adopt these kind of modern EHRs. And that's in stark contrast to what we're seeing with this moment in AI, where healthcare has really embraced that technology. And it's really interesting to contrast those two revolutions. So with EHR adoption, it was really spurred by a federal mandate, which was informed by some really specific regulation. And unfortunately, there were some side effects. So we did get the rapid adoption of electronic health records across the US. If you look back at this graph here, from 2009 through 2020, you had this basically vertical line as far as hospitals adopting modern EHRs. But it did have some secondary effects that we're still digging ourselves out of. Because of the really well-defined regulations, it really shaped the user experience. There was a lot of extra clicks that were designed in the EHR, which I know many of us as physicians have lived through, where in order to meet the meaningful use regulation, we needed to attest to a lot of different things that involved a lot of extra clicks. There was also a lot of non-physician involvement in the design of those systems, and so we were stuck with some really suboptimal user experiences, especially from a physician and nursing standpoint. What gives me a lot of hope with this moment in AI is that all of this excitement and adoption is really based more on market need. And what's been really great to see is all the startups that have been physician-led. If you think about startups like Abridge that are led by Shiv Rao or founded by Shiv Rao, who's a cardiologist. There are a number of other startups that we at Hopkins are piloting that have physician co-founders right there. And I think that we have a great hope here that this new AI revolution will be much more physician-centric and really try to address some of the missteps we made with our earlier computer revolutions in healthcare. Now, with that being said, at Hopkins, we realized back at the end of 2022 that AI was something that was going to be revolutionary. And in early 2023, we stood up a responsible AI task force. And this really encompassed all of Johns Hopkins, not only the hospitals, the Johns Hopkins Medicine, but also the university. And so we had members from the School of Engineering, we had clinicians, lawyers, government relation experts, health IT experts, AI experts really come together to figure out what does responsible AI look like in the Hopkins context. And we really felt that at that time, it needed to align with Johns Hopkins Medicine values, which include excellent discovery, leadership and integrity, diversity and inclusion, and respect and collegiality. And so based on that, we came up with these 7 core principles of AI use. And so you can see we were really focused on making sure that AI tools and models that we adopted valued fairness and inclusivity, that the way those models are meant to be implemented, that they were transparent, understandable to the end users, that we had oversight and accountability as far as the output of those models. And I think the bottom spoke here is really key. Whenever you talk about any AI system, data is by far the most important thing. How the data is curated, how we keep our patient data private, how we make sure that any vendors that we work with, that we have really great agreements with them, really strong agreements that really protect our patient privacy and make sure that patient data isn't used in a way that would be in contradiction to Hopkins values. So thinking about that, really the charge for us is to make sure that there's the responsible use of JHM data in the implementation of AI in any kind of production environment at Hopkins, and it's consistent with the mission and values of Hopkins. I would say the other great decision that this group came up with was really to embed our AI governance inside our existing software intake process. This was really key. We did not want AI to be something separate from how we do the rest of our health IT. And at Hopkins, one of the things that I'm most proud of, not that I developed it, but I'm glad to be associated with it, is our software intake process. And this is a governance structure we have where whenever anyone at Hopkins Medicine requests either new clinical software, but even new hardware that may have embedded software in it, that they have to go through this unified process that involves not only IT risk assessment to make sure that we aren't taking any kind of risks as far as safety to patient data or any of our clinical systems, but also includes our legal team to make sure that we have robust business use agreements with folks, data use agreements that our data is not being used in a way that we wouldn't like, also with our um, procurement folks so we're getting the best deal possible, and also with our health IT team to make sure that whatever we buy can integrate into our existing IT systems. And so what happens is that we have a unified process for any software. And if it does happen to be AI software, it gets directed to one of our three AI sub-councils. So we've set up three different councils. Our first council is our clinical council, clinical sub-council, which really looks at any kind of AI that's helping to enhance patient care or clinical outcomes. We also have an imaging sub-council to really tackle any kind of imaging software. And it's not just in radiology. This includes cardiology, pathology, and ophthalmology. And this is an area of AI that's been exploding. If you look at the FDA submissions for medical devices, the vast majority are in the imaging space. And then finally, we do have an operations subcouncil that's really looking more at enhancing healthcare operations and administrative workflows. The kind of tools that we've looked at recently in our clinical subcouncil, which I co-chair, we've looked at things that have enhanced clinical documentation. We're really interested in chart summarization currently, and then looking to see what we can do with AI that helps with clinical decision support. Though, to be honest, we haven't had many tools in that space right now. On our imaging subcouncil, we've been looking at tools that the most obvious are ones that help with diagnosis and help our imaging physicians find never events and things like that. But we're also looking at administrative workloads, things that make it easier for us to be more efficient with the resources we have, and also looking at the quality of the images that our technologists are producing. And then finally, in the operations side, we've been looking at many different tools. Obviously, as all of us that are participating in healthcare in Maryland know, capacity and throughput are key to making sure our patients and families get the care they deserve, but then also looking at ways we can optimize our staffing and scheduling, looking at our supply chain and resource management, and then also looking at ways that we can make it easier for us to get financial and operational forecasting from these models. Now, one thing, again, I think that's really key here is the composition of these subcouncils. We've been really lucky at Hopkins Medicine to have many, many physicians volunteer their time, basically for free, to join these subcouncils. You can see all the folks that are in blue are physicians. We have a multidisciplinary team, but we are really focused on making sure that we have physicians at the table that are looking at these AI tools and making sure that they're ones that enhance patient care and really help make patient care safer, but also easier for our stretched clinicians at this time. Now, when we evaluate any kind of AI product, we have a standard rubric that we look through, and I highlighted in blue some of the key questions we ask. So the first thing we always start off with is, what is the problem we're trying to solve? Peter Green, my predecessor, this was his favorite question to ask. And we want to make sure that that is front and center when we're thinking about any kind of AI tool, that we really have our focus on what is this helping? And then I think soon after that, we're really interested in trying to be very thoughtful in the kind of metrics. How do we define success? How do we know that if we're going to run an AI pilot, what does that look like? What would let us shift from pilot mode to widespread deployment? And so really spend a lot of time thinking through that. We're also really trying to get more sophisticated in terms of the ethics around these AI tools. Is it fair? Will it be used ethically? And then we also need to look at, we have this shiny new object. We get very excited about it, but are there new risks that could be potentially uncovered if we deploy this tool at scale? And so we really like to be thoughtful about what are the kind of tools that we're going to pilot and eventually deploy all across Hopkins Medicine. Now, our subcouncils really have 4 different decisions that you could make. Most commonly, the pattern that we've had is we've usually started with a pilot anywhere from 3 to 6 months with some really clearly defined metrics. If that pilot is successful, we have the submitters come back to the AI Council so that they can then either endorse the pilot or potentially, if the results aren't that great, and we've had a couple this way where we've just disapproved the pilot and not gone forward. And then sometimes we just don't have enough information at those subcouncils. And what we've realized in our process, especially in the clinical subcouncil, it's been surprising how quickly we can have really robust discussions, but they really depend on our subcouncil reviewers taking the time to really dig into the tool ahead of time, interview both the technical and clinical business owner for those tools. And we've had some really great, thoughtful discussions around how to deploy these tools. Now, that being said, we've had about 10 months of experience with the subcouncil at this point, but there are areas for growth that we're looking to improve across Hopkins. The first one is really making sure with the explosion of AI apps that we are developing a robust inventory of the apps that we are deploying at Johns Hopkins Medicine. Really, we want to make sure that this is a resource that any Hopkins Medicine employee can access. And we do this in the form of what's called a model card. So that goes down and makes sure that all the answers that we had asked previously in our evaluation rubric are answered clearly. We also have documented the decision of our subcouncils in that. And we have then also other technical details around when was the model deployed, when was it last updated, all of those kind of things. So we want to be as transparent as possible to our employees as to the AI tools that we are using at scale at Hopkins Medicine. Another area, as I mentioned, that we're really interested in is getting more sophisticated in our evaluation of the ethical conundrums that come with deploying AI tools. So with AI, there are definitely opportunities. At scale, we can detect bias and potentially enable correction of that bias. And if used correctly, we could improve equity with these tools really allow us to increase access to care. But on the flip side, these tools, if they have bias training data, can actually cement the kind of biases that exist in society as a whole. And so we really want to be very careful and try to be as nuanced as possible. This is definitely an area that I would love to say we are perfect at, but it's definitely something that we wish to continue to grow and get better at. Now, when we think about the ethical AI questions, we try to think about these things, and I really want to credit Deborah Matthew from our Berman Institute of Bioethics with coming up with these questions. So the first thing is really thinking about, is this system sufficiently important that its costs outweigh its benefits to society? And when it comes to AI, we actually don't need to just think about biases, but there's a environmental cost to running these models. It's definitely something that our medical students really think about. When we had our intro to AI class, one of the questions that they really hammered on instructors on was, these tools use up a lot of water, a lot of energy. Are we being thoughtful about the tools we pick, and are the solutions they're providing worth all of that? And so that's something we like to really keep in our mind. I'd love to say that we are sophisticated in answering this question. We're not there yet, but it's definitely something that is front and center. Same thing with the kind of metrics that we're looking at to see, are there potential harm or bias with the use of these tools? And are we making sure that all groups that we treat and care for at Hopkins Medicine are getting equal benefit from the implementation of these tools? These are definitely questions that we continue to wrestle with, and hopefully we'll get better and better at answering as we get more experience with evaluating these AI tools. Other areas that we're really interested in. So as you know, these generative AI tools are amazing, but it is really difficult to be able to, at a large scale, judge their output. So a great example of this is we are piloting a tool currently that helps draft a discharge summary, a hospital course note for our inpatient physicians. And right now, our only way of evaluating it is what folks in the field called vibe checking, which is we get physicians to sort of grade the output on a sort of qualitative measure. And we'd love to get more sophisticated in this. There are definitely folks around the country that have thought about this deeply and have actually, and this sounds quite Kafkaesque in some ways, but have trained other AI models to judge the output of the AI model. And so what they do is we've developed a number of quantitative scoring systems. PDQSI is one of the more prominent ones, which are a way to judge the accuracy and completeness of a hospital discharge summary. And so you get experts to grade a number of AI outputted discharge summaries that way using this very structured system. And then you actually train a second AI model to do that. These are things that we're having to wrestle with because we want to make sure that we have a way at scale to be able to judge the output of these models. One of the other things that comes with generative AI that we have to keep in mind is that if there are any small tweaks to the model, they could have an outsized effect on the output. So all of a sudden, if on the back end, the generative model is changed slightly, it could degrade the quality of the output. So we have to have ways to be able to judge that. And so that's something that we're wrestling with and trying to come up with great solutions for. Another area that we're trying to figure out is how much of the AI output do we need to keep? So, and this will come actually later in this talk, but thinking about our AI scribe. So currently, obviously, we retain the note that's the clinician signs based on the AI scribe output. But for how long do you actually keep the transcript of the AI scribe or the recording? Currently, we don't include that in the legal medical record. Yes? Did someone have a question?
No, I think he muted. Dr. Bourne was.
No worries, no worries. But these are things that we're thinking about. The same thing, we run a AI mammography tool that helps our radiologists identify mammography lesions. And that is something that output we would want to retain. But I think that that's something that we think about with every AI tool that we implement. What of the output are we going to keep in our legal medical records for later discovery and be able to make sure if we have an audit trail, if any decisions are based on that AI output. And then finally, this is something that I think is really important to this society to think about. But how much in physician documentation do we need to acknowledge the use of AI? And that's something that we're trying to think through. And we'll talk about that. I think it'll become more concrete when you look at the variety of AI applications that physicians have access to now. And how much of that do we need gets covered by our routine documentation and thought process that we put into our assessment plans versus do we need to call something out specifically to say that AI was used in this case? So I know that this is sort of a slight audible, but really would love to think about sort of the popular categories of AI apps that are being used currently in the clinical space. So the first one I really think is our ambient AI scribe, and we'll talk about our experience, and that has been our largest widespread deployment of AI at Johns Hopkins Medicine. But I think that there are some other areas that have a lot of excitement right now. One is around clinical reference materials and using AI to help answer clinical questions. At Hopkins, we're really interested in chart summarization and that being a use of generative AI that could really help with the physician experience and physician workload. And then, as I mentioned before, medical imaging and diagnostics has had a huge explosion in the number of AI tools that are out there. There are some other use cases that are also starting to gather a lot of momentum around helping physicians with coding, having AI draft patient communications, predictive analytics and risk stratification, which is more of an older set of AI tools really around machine learning. And then there's a lot of interest also in language translation and can AI tools get up to medical grade translation. And so we can really help our patients and families for whom English is not their first language. So the first category of tools I'd love to talk about is the ambient AI scribe. And so what that is basically it's an AI software that does, I would say, three things. The first is it listens to the conversation between a physician and a patient. It then takes that transcript and runs it. The most sophisticated versions of these run it through natural language processing, which usually involves uh, these small and medium-sized language models that these companies have trained specifically for medical terminology, so they understand, terms like heart failure and all the different drug names and drug categories that you may be discussing with your patients, and any of the kind of diagnostic tests that you may be going over. And then finally, that's usually fed through what we think of as AI, which is a generative AI, large language model to help actually create a note. So the feedback from our clinicians in using, our physicians in using these tools has been overwhelming. I think that folks have really felt like these tools have been able to help them connect with patients better. They are no longer having to constantly type at the same time that they are interviewing the patients. They find that they can write notes faster and that the quality of the notes are really of a high grade. And so it's been a really positive experience for them. At Hopkins, we've seen that in our pilot user group, uh, they've had a reduction in time in notes by anywhere from 2 to 3 minutes, depending on the specialty. And we've seen this across the country. Kaiser Permanente had quite a comprehensive study of how their ambient scribe technology really reduced physician time in writing notes. Now, what AI scribes across the board are really good at, they are very good at capturing the HPI. What they are variable at, sort of depending on your specialty, is assistant implants. They're really good, I think, and optimized in the primary care setting. And then other specialties that have notes that are similar to primary care or internal medicine have seen some really good assessment plans. Other folks, like in emergency medicine, have had some sort of variable success with that. What ambulatory physicians also have really liked with AI scribes is the ability for you to quickly be able to create very good patient instructions. So really being able to help patients understand what happened in the visit and do something that doesn't involve double documentation, because this can be generated by the AI scribe very quickly. The AI scribe is also great at handling multiple family members and multiple speakers and parsing out who is who. And then finally, as you can see, I'm still in the hospital, so there's a rapid response going on at the same time. I may mute myself for 1 second so that announcement. Cool. So one other thing that's been quite magical with the AI scribe that we use, and this is not unique to that, is the ability for the scribe to, if you're having a conversation, let's say you're a native Spanish speaker and you're having a conversation with your patient who's also a native Spanish speaker, for the scribe to be able to translate that interaction into a note in English that you can then use as your progress note for that visit. And most of these scribes can usually handle a number of languages with that. What they're not yet good at is if you're speaking in English, you have a translator, and your patient is speaking in a different language. That's a nut that still needs to be cracked. Now, there's been an explosion of AI scribe apps. What's been fascinating is, this technology a year ago, and I think Gene mentioned this, was considered magical, but really at this point has become table stakes. And so the basic technology of recording a visit between a physician and a patient and generating a note has become pretty commoditized. And there have been a number of different entrants into this space. At Hopkins, we use a bridge. The Microsoft DAX is very popular along with Ambience, and then there have been some other entrants into the space. Doximity is very popular, and Epic, our electronic health record platform, has announced that they're also getting into this game, which is definitely, I think, caused a bit of a shudder amongst the startups that are in this space because it's hard to overcome your default. But what's been really fascinating is that each of these startups has realized that, as I mentioned, the actual scribe technology is commoditized. And so you need to be able to do features on top of just that basic functionality. And so, for instance, Bridge has really focused on developing specialty notes because they realize that's an area of weakness. So if you look here at a bridge adoption across Johns Hopkins Medicine, at this point, after about 10 months of widespread deployment, we have around 20.5% of our physicians using a bridge. And when we say active Abridge users, we have a relatively low threshold. So you need to have used a bridge consecutively for 3 months and at least generated 5 notes. Where we've seen really great adoption is in our primary care groups. So we have a group of physicians called Johns Hopkins Community Physicians. There are around 360, almost 400 physicians. And in that group, we've really gotten to about 70% of our physicians in that group, physicians, NPs, and PAs, I should say, have adopted a bridge. And really, you can see that this reflects the fact that the tool is optimized for primary care, ambulatory visits, but also that was a group that desperately needed help. These were folks that were spending nights and weekends writing notes, and it's been quite dramatic, the effect that this ambient scribe technology has had on their work-life balance. Other areas where we've actually had surprisingly good adoption, neurology at Hopkins has quite high adoption amongst the School of Medicine faculty, and that's been really a great partnership where we've had a couple of School of Medicine neurology faculty that have really taken it upon themselves to proselytize a bridge usage, and have gotten a lot of their colleagues to adopt a bridge. And one area that was actually really surprising to me is the amount of adoption we've had in neurosurgery. And that's been with no intervention from our health IT team. This is just something that the neurosurgeons themselves have really found value, both amongst the faculty and the residents in using this in their clinic visits. It's been quite surprising the kind of sort of the groups that have found value in a bridge early on. Where a bridge has really focused a lot is they realized that other groups, other specialties, the basic abridged product just isn't robust enough. And so they've been deploying specialty notes. Since August, we've had an emergency medicine specialty note that's really helped with emergency medicine adoption of a bridge. We're still not where we'd like to be, but it's been a dramatic increase from where we were at the beginning of the year. They also now have a behavioral health note that can be used by our psychiatrists, and also a pediatric well-child visit note that have all been well received. And we've actually got Hopkins clinicians beta testing a number of other specialty notes to try to make sure that they're as helpful to our physicians as possible. Other areas, as mentioning, really just the basic transcription of a patient visit isn't enough. And so a lot of these startups are really trying to add additional features to the basic note generation. So a bridge has the ability now to display discreetly what are the diagnoses that it captured during the visit. So you can make sure that you agree with those prior to writing the note. Plus, they're written in a way that is coding and billing appropriate. So you're maximizing your documentation. We also will have shortly a pilot running with the bridge in the next month, where a bridge will tee up medication orders based on what it hears during the patient encounter. So if a new medication was discussed, it will tee that up as a new order. If a refill was requested, it'll tee up that order. We obviously need to pilot this feature and see how it works in real life, but this is another area where we could really have some gains in efficiency and really help our physicians get through their days in in an easier fashion. We're also really interested in prior authorization, both for medications, but I think initially for procedures. So for operative procedures, trying to help physicians coach them through the kind of things they need to go over with the patient in order to get all of the right prior authorization for a surgery or for a procedure. And then we're looking at things, I know in the primary care space and the ambulatory space, this is a real opportunity is to try to make sure that we capture those HCC diagnoses and that they're written in that MEAT format. And so you get value and are able to really maximize the documented complexity of the patients that you take care of. What some other folks are looking at is, can we also have integrated clinical guidance? So Abridge, about a year ago, announced a partnership with UpToDate. And so they would integrate that into the notes. And so you'd have evidence-based guidelines that were embedded in your note. And that's something where we'll talk about this actually in the next set of apps around clinical reference, but Open Evidence has its own scribe application, and what they think is their differentiator is their ability to embed great guidance into people's assessment plans. And then I think what everyone would really love to have in order to make the notes as robust as possible is, can you get patient context from the electronic medical records? And that's somewhere where an EHR vendor like Epic is going to have a massive advantage over any other startup. It's access to the chart and being able to give the scribe context, the fact that, hey, this patient has all of these past medical history. These were the problems from the previous progress notes. These were the problems from the previous specialist progress notes, really trying to make the note as robust as possible. And so physicians have to do as little editing as possible. And I think that's somewhere where everyone is trying to get to, but I suspect that Epic will always have the upper hand in that situation. Now, I think the other area where there's a lot of excitement is around clinical reference materials. I think of these things as tools like UpToDate, where it's trying to deliver an answer to a clinical question that you have. And AI should be really good at this. I would say at this point, the market leader in AI-based clinical reference materials is Open Evidence. They are by far the most popular, but existing vendors like UpToDate, Dynamed, know that their future lies in AI, and they are working feverishly to get their AI products up to where UpToDate, where Open Evidence is at this point. And then it's also intriguing what Doximity is doing in trying to aggregate a lot of these different AI apps into their platform. And so they bought a startup called Pathway Medical and have incorporated it into the Doximity app. And so that's available to clinicians really as this kind of all-encompassing product where Doximity is now an AI scribe and can also answer your clinical questions about the patients and help you draft prior authorization letters and all of those kind of things. It's really an interesting play on their part to try to be the one-stop shop for a lot of physicians for AI tools. Now, just getting back to Open Evidence, what they really try to position themselves as a medical Google. And what they have signed are user agreements with or partnerships with New England Journal of Medicine and JAMA, and look at just millions of peer-reviewed studies to try to be able to answer the clinical questions that you have. And it's been popular. Like at this point, they're getting about 400,000 queries per day by US physicians. And this is open. You have to register, but if you are a US-based physician with an NPI, you can register for Open Evidence. And it is something that I often use when I am seeing patients. I think that the output is good. I would say that uh, with any kind of free app, you always have to worry if are you the customer of that product, or are you actually the product? Are they using your search queries um, to do further development? And so I am very careful about what I enter into open evidence. And I think that's always just a great rule of thumb for any of these AI apps, whether it be ChatGPT in OpenAI. If your organization does not have a BAA with these tools, I would strongly discourage anyone from entering any kind of PHI in these apps. So it's much better to sort of don't give an actual patient age, just say that your patient is greater than 65, or if you're having to enter in a lab value, like an AST value or something, just put in a range. Don't put in your patient's actual lab values there. You can still get really helpful output from it. But always, I think, a good thing to keep in mind. These are useful tools, but you should be careful if you're using an app that your organization doesn't have an agreement with. You cannot guarantee that any of your patients' health information won't be used in a way that you may find disturbing. Now, Open Evidence has additional features. So they are advertising now this kind of deep consult, which uses more of a more advanced reasoning model for rare and complex diseases. As I mentioned, they do have an AI scribe. Again, I would be a little leery about using this unless your organization has an agreement with them. There are probably better, safer PHI apps to use that can safeguard your patient's PHIs, especially one that you pay for and that you have a data use agreement with. Now, the other area that we're really interested in, especially at Hopkins, is chart summarization. Generative AI tools should be really good at doing this, being able to both do natural language processing and then being able to condense key clinical information from the patient's EHR. Because I think all of us realize that as the years have gone on, our patients have gotten more and more complicated. They have more and more chronic medical conditions, the number of tests they've undergone, the number of hospitalizations they've had. It is really hard to keep up with their clinical care. And so this is an area where this could be a great time saver for physicians, but I think also help with our decision making, since we can get a much more condensed view of someone's care. So in this space, again, there are a number of products at Hopkins that we're looking at. We've looked at the Epic provided chart summarization tools. We are going to be piloting with a vendor named Evidently in the next month. And then we've also looked at a couple of other vendors in the area, Regard and Glass Health. But we really think that this is, after the AI scribe, this could be the second area where we could really help clinicians with their burden of work. And AI could really play a great part in that. And then finally, before I finish, really wanted to talk about medical imaging diagnostics here, just because of the sheer volume of tools. I know that radiologists are a minority of physicians, but this has definitely been an active area of AI, and I think will continue to be that way sort of as we go forward. And really, as I mentioned previously, we can bucket these medical imaging tools in a couple of different categories. So, for instance, at Hopkins, we have a agreement with Blackboard Analysis, and really, what this is trying to do, what that company is trying to do, is aggregate a number of these machine learning models that have been developed to help radiologists with diagnosis and be able to deploy that easily and pilot them so our users, our radiologists, can evaluate them and see if these tools are actually helpful. Because while there's been a large volume of medical imaging AI tools, they are of variable quality. And so that's something that we need to be able to judge for ourselves, whether for the patients that we see, whether these tools are helpful. we're also really interested in AI Doc, which is a tool that is looking that's used mostly in plain films and CT scans, but as an always on type of modality that can help us detect, especially never events, things like brain aneurysms or uh, aortic dissections, those kind of things. If we can have some tool that could really help our radiologists effectively find those tools without making it overly burdensome. And then RAD AI is another really popular imaging um, AI platform that is more aimed at the documentation and throughput of radiology than image analysis, but I think another area where there's a lot of growth and excitement in the medical imaging space. And so I think I just downloaded my brain. And so happy at this point to have a discussion and answer any of your questions.
Yeah, thank you so much, Dr. Sridharan. It's not only you provided that overview and the very thoughtful governance or the structure Johns Hopkins has to get these new tools, and also some examples of tools for our physicians, right? I mean, this is like an important time we are in. Sometimes we have to use it, but what is the right path to use it, right? I mean, institutions have policies, but what about the other physicians? So right now we can open up for Q&A or any other comments. If you raise your hands, I can call your name so we can have a discussion now. Dr. Ma.
Hi. Sorry, I got on a little bit late because I was on another meeting. It was a great talk, and thanks a lot for giving it because, I'm a radiologist, and so seeing that everything that's coming along in terms of all the other AI stuff is very interesting for me. And we work with AI products, and you're right that they're very it's very variable. Like I'm working with a prostate one that highlights all sorts of incorrect things. You know what I mean? And I'm trying to figure out, well, what do I say about what if I was in a court of law and they said, well, why didn't you call that? But I'm like, well, that's a piece of bowel air that's causing an artifact that's being detected as a prostate lesion that's really not there, right? So I think that, I'm just wondering how we're working through all of that, and yet there are some great tools. That some of the hemorrhage tools that pick up hemorrhage are good. Aortic dissection, I get a little bit nervous about because there's so much motion at the heart, at the aortic root, and so all of these things are fascinating, and I'm sure obviously, that they will keep going on, but I am interested to see, where how you organize that and how you sift that out and do the quality control on that.
Yeah, no, I think one thing that we've realized, I know you as a radiologist knew this already, but being a radiologist is really hard. And 10 years ago, there was the thought like, oh my gosh, there are going to be all these AI tools. We will no longer need to train radiologists. And what we quickly realized is that you guys earn your keep. There is no one AI tool that could replace the uh, clinical acumen of a radiologist. And definitely it's true. There are lots of tools out there, and we really try to make sure that if we're going to deploy something across radiology at Johns Hopkins Medicine, that it is something that is aiding our radiologists. We do not like having lots of false positives just because that just degrades the experience. You are now having to sort of evaluate all of these false positives and having to document that, like, yep, I agreed with these ones, but I disagreed with this one. Or I'll more commonly disagreed with these 10 and agreed with this one finding that the tool had. And we really want to avoid that experience. We don't think that is going to help our radiologists. And so we really like to be, we've evaluated a lot of tools. We've deployed very few. I think at this point, really, we have a mammography tool. That's the only one that we use across Hopkins Medicine for radiology.
Thank you. I just was wondering about it, so thank you so much.
Great. I feel like Hopkins is a little bit more conservative. I don't know that's the right word, right? Really going very thoughtfully on this. So let me go to next thing I see. I saw at least there's a chat question, and then Dr. Yog, then Dr. Day. Okay. The chat question is, what are your favorite tools in each subdomain? If such tool exists, for scribing, education, and chat summary.
So I think that I've only had experience with the bridge in with the AI scribe tool. I know that we did pilot DAX as well at Hopkins, and in the end, our clinicians favored a bridge at this time. Uh, as far as clinical reference, as I mentioned before, I am a fan of open evidence. I do think that it works really well. I often use it to help make sure that I haven't missed anything in my differential diagnosis. Um, and I find that its output is quite helpful in that way, along with, answering questions like, hey, I think I remember what the starting dose for Xarelto is for a PE, but you can just type that in the chat in open evidence, and it'll give you, a quick summary without having to look in some other reference guide. So I think that's great. I have I as many of you I'm sure are participating. I do these longitudinal knowledge assessment questions, and so when I first started doing that, I actually would have a number of different models. Like I'd have ChatGPT, Open Evidence, up-to-date AI, along with like Google Gemini, and see how well they all answered those questions. After I sort of typed in a summary to them, and found that Open Evidence did the best job of answering it consistently. It doesn't always get it right, but it's a lot closer than the other ones. So I think that probably wins the cake there. Um, at Hopkins, we have a partnership with Microsoft. So I use Microsoft Copilot for sort of other administrative tasks. It may not be the best one, but it's sort of HIPAA compliant. I don't have to worry about what I ask it.
I heard 40% of US physicians are using open evidence. It's a high number, right? It's becoming so popular.
Yes.
Anyway, so I go to Dr. York next.
Yes, thank you very much. This was excellent and very thorough. Um, and Edmini and I are both on the AMA Informatics Caucus as well. And the certainly clinical decision support is a tough one, and that came up in our discussions of how to form policy around it and how to increase transparency, how to let physicians that are using it know where the data come from, what the papers are, which is very challenging. But and that just was sort of a by the way, and this is a tough problem. But it would be fascinating to have a sort of a regional work group on AI topics. I'm with Luminous Health. I'm an orthopedic surgeon, and so we use DAX Copilot, which we all love, although it certainly could be better. It's best obviously for the HPI. We all love it for that. And there are some details. I'm talking away. I'm trying to talk in a way that makes it that I think will make it think it picks it up, and it just doesn't. And I've talked to the Microsoft folks about it, and there are ways you can go behind the scenes and tweak some things, but it is limited. Like for instance, I'd love to be able to put to date stamp each section of my HPI because of my note, HPI, physical, and so on like that. Because I'll keep two or three in a row, and it's confusing to see which came from today's visit versus last month or whatever. Um, that's the kind of nitty-gritty stuff I would love to be able to, and maybe Microsoft DAX or some other entity would be then interested to work with this large group of physicians across Maryland and so on. Has anyone thought of that, or have you heard of such a thing?
I haven't heard of a large consortium that way. I know that we definitely work at Hopkins very closely with the bridge. As I mentioned in one of our slides, we have a number of our physicians both doing alpha testing of notes and beta testing of these specialty notes. Because you're exactly right, Dr. York, that for specialties like orthopedics, there definitely is a lot of room for improvement in making the output from these scribes more consistent with the way orthopedic doctors document their notes, both I think the HPI, but definitely the assessment plan and the physical exam. Those are areas that have a lot of room for optimization, um, and trying to make the output meet your needs. Because that's the end of the day. We'd love it to have it so you had the least amount of editing to do. You
Right.
visited your patient, you made a lot of our physicians do what's the term is monologuing. So like after you finish with the patient or before you finish with the patient, they often will speak into the scribe and just
Right.
give like a
Exactly.
quick summary of either medical, past medical history or more detailed plan that you need for your own note that you may not have explained to the patient
Right.
specifically just because that may be too overwhelming for them. That has been ways that they've found to make the output better, but I think there are definitely specialty specific tweaks that need to happen as well.
But certainly, I would think that our MedChi group and
Mhm.
maybe we could start a kernel of people interested in this type of thing, maybe at Hopkins and Luminous and or other folks. And it could just be you guys could be the germ on which this stuff grows. Certainly, the level of organization you have is very, very impressive. I did take that 10 by 10 informatics course through AMIA, which
Mm.
was a huge eye opener and a very broad spectrum view and learning experience for informatics. So I loved it and would love to be able to add to that.
Thank you, Dr. York. I think I'm glad that MedChi could be a coordinator, leader in this kind of a thing if we ever going to set up something to coordinate, hospitals and institution locally. And Dr. Day, over to you, and then I see a chat question.
Yes, thank you. Hi, I'm Dennis Day. I'm a private practice neurologist, and I also do some hospital work. We've just started to use the ECW embedded scribe, the Suno, in the office. My nurse practitioners are using it, and I do worry about the verbatim transcript that this thing keeps, because ultimately we'll have to edit the note, and it has to be sort of our understanding of what was said, and some of it comes from the AI, some of it comes from the provider. So my question is, have you had any discussions with your risk management people as to, what happens if a transcript of this, gets played in court and then people are second guessing as to what the final editing of the note should have been? Has there been any discussion that you're aware of?
Yes, so definitely our lawyers were involved in this. What we currently do with our ambient scribe is that we keep a copy of the recording, the transcript for 30 days. So I guess in that narrow window, it would still potentially be discoverable. But after that, it's deleted. And actually, if you use, for us, if you use the Abridge app, the physician actually has the ability to delete the transcript as soon as they would like, even before that 30 days. But at scale, uh, we delete those transcripts after 30 days, so they're no longer part of the legal medical record or discoverable at that point.
So I'd have to find out how that is with ECW, I
Yeah,
guess.
I would ask them, but that's usually pretty standard. I'm sure they're not interested in holding on to these
Yeah,
records for super long. Like the storage cost would be
yeah.
humongous after a while.
Thank you.
Thank you. And the next question maybe falls in the same vein. Thank you for the presentation. And can you please speak to the risk of hallucinations or false fact when a physician fails to catch it? I'm more thinking of False Claim Act concerns when submitting a prior authorization information to payers.
Yeah, no, I think that it's always a challenge. We do place quite a bit of responsibility on the physician who's signing that note. We don't see a huge amount of hallucinations with the bridge, but it does happen every once in a while where it misinterprets what you said, and that is something that we assume folks are reviewing those notes pretty thoroughly prior to signing it. And then as far as prior authorization, we aren't doing a lot of letters generated with a bridge or scribed that way. But yes, ultimately, if you're signing a note, our view is that you are responsible for the output at the end, even if AI helped you generate the note.
Dr. Taylor?
Yes, thank you very much for the good summary talk. I have some concerns, and I wonder what your take on these would be, and that is that using the scribe function, I think someone could make the argument that that's part of the legal medical record and can't be destroyed if it, exists at the beginning of somebody's medical record. And the question sort of related to that is, do you think that the HIPAA regulations need to be changed in order to accommodate AI use in medicine? I mean, I'm not a lawyer or an expert on that, but I would think having signed some of those HIPAA agreements and data sharing agreements that AI doesn't really qualify 100%. So I'd wonder if you'd maybe give your thoughts on that. Also, do you get patients' permission that the interview is going to be recorded? And of course, then if the patient knows it's recorded, but then you're going to erase it after some period of time, I could see that being a malpractice issue as well. And again, I'm not a lawyer, but I assume you've had your legal team look into that issue as well. And finally, the last thing is, as you probably know, that in recent years there's been a percentage increase in the feelings of burnout that physicians have, and what they frequently mention is the requirements for documenting, their medical records, which become onerous, and secondly is prior authorizations. So do you think artificial intelligence tools like scribing are going to help that or make that worse?
Yeah, definitely. I guess I'll start from the back. So as far as physician burnout, that is a huge driver for why we're so interested in these tools at Hopkins. And I think many different health organizations are equally interested. They realize that the current documentation burden on physicians and the general administrative burden for physicians is great. So I think that scribes are one part of the solution. There is definitely a huge interest in a lot of startup and other activity in the prior authorization space. This is definitely an area where this is ripe for having AI really help reduce that administrative burden and get to an answer much faster between the physician and the payer. And some of these actually are not even AI tools. Like some of them are much simpler than that, but I think that some of the more sophisticated things that we need to document, that is something that we are looking at actively to figure out how we can get that off the we would implement either on a pilot basis or across Hopkins Medicine, that we have really strict agreements with any of these vendors as to how they handle our patient data, uh, what they retain. We really don't. We ask them, they can't retain any of our patient-specific data, and even de-identified data. We like to really have very clear guidelines as to what can be stored, how it can be used, and all of that. So that is our patient privacy, and their data is at a one of the first things we think about whenever we're engaging with any vendor. Now, going backwards, as far as retaining asking if patients want to be recorded, definitely in Maryland, because we have strict laws around any party knowing that they're being recorded. It is part of our standard policy that you have to let the funny part is you actually need to let the patient know that they're being recorded. The AI part is sort of secondary, but the actual Maryland law that we need to follow is around the fact that someone is being recorded, and that has to be known to them prior to starting that. And then, as far as what's retained in the legal medical record, our lawyers have thought about this. Definitely at Hopkins, we have some of the most conservative and thoughtful lawyers, and so they definitely thought about what we need to retain in the legal medical record. And after a thorough review, they felt that it was reasonable to delete those transcripts and really just have the patient note, the signed physician note, be our source of truth and be part of our the legal medical record.
Thank you so much. I don't see any questions or comments or hand raised. So with that, we want to thank Dr. Sridharam for your outstanding presentation. We really, we learn a lot, and then our members actually enjoyed it. And then also our audience for their engagement and participation. We are in this journey together, right? Like we need to learn it. And then in 6 months, it might be changing. You have to come back and do a whole new presentation. So that's how it goes. And so with that, I would say, if you are not a member of MedChi, please consider being a member. Our goal is to educate and then help our physicians in Maryland. And then there's another, if you want to get the CME credit, you just have the QR code. And then our next step is to go into a little bit more detail in different disciplines and how that might be tied into like a healthcare ecosystem in general. So one of our Hopkins physicians, I'm sure Dr. Sridharan knows very well, Dr. Alvin is going to talk about AI in ophthalmology. And then next following one would most likely radiology. We are just trying to go into details and help our clinicians to understand some of the tools out there. I think with that, we can adjourn the meeting. Good evening, everyone, and thank you for joining.